Hello, welcome back. I want to go through uh, Unit 9 as well as Units 10, 11, and 12 case studies, as well as the PhysioExes in this video. Before I get started, I just wanted to say a couple of things. First of all, we only have a little less than 3 weeks left, and most of you have been keeping up. Some of you have finished the entire course. So great job to all of you. I am in the process of grading. So basically, over the next couple of weeks, you'll continue to see numbers pour into your grade book for the assignments that you've done. So if you have questions, again, please email me. If you need to meet in Zoom for any reason, please email me and we can set up a time. This will be the last video that I do, so it's going to be fairly long. I don't think it's going to be too terribly long, but I'm going to go through case studies 9, 10, 11, and 12 first. And then after that, I'm going to go through the last couple of PhysioExes, the respiratory PhysioEx, the digestive PhysioEx, and then there's a pH PhysioEx, which is a two-parter. So there are going to be 4 PhysioEx activities. They're all relatively short, same with the case studies. So I decided, you know what, I'm going to go ahead and compact everything into one video, and you can go through and gather what you need from there. Again, a couple of reminders, exams, the whole course is open until 11:59 p.m. Monday, April 26th. So as Monday, April 26th comes to an end, you'll no longer be able to take exams, drop boxes, the course will be closed. So at that time, anything that you've done, and again, I'll be continuing to grade. So if you're turning things in that day, I'm going to be grading things as they come in. So my goal is then to have everything done Tuesday, the 27th, really when I go to bed even. So Monday, the 26th into the 27th. So again, try to have everything in. The exams, remember, are unlimited attempts. The highest score will be recorded in your grade book. The drop boxes for the case studies are also unlimited attempts. And then the drop boxes for the PhysioExes are also unlimited attempts. So if you're planning on doing any extra credit PhysioEx activities, you can put those in the drop box that those activities correlate with or correspond to. Again, all drop boxes are unlimited attempts, so you could really put it in any drop box. So just put it somewhere, and I'll get the notification, and then I'll grade it. So again, several of you have turned things in that I haven't graded yet. So I keep, quite a backlog. So I will, again, keep grading over these next really couple of weeks. So most of unit, unit, unit 3 stuff is graded or almost done being graded. All of units 1 and 2 should be done. So there may be a few items that came in a little later that are lingering out there, but unit 3, I'm just about done. So you should start seeing numbers pour in for unit 3 stuff over the next couple of days as I get those uploaded into Blackboard. Let's see, what else? I don't know. Yeah, I think at this point, all of you know what to do and know what you're doing. So I want to get into these case studies. I hope you enjoyed those. Oh, and again, don't forget the Padlets beyond. And those have been excellent comments. I hope you've enjoyed all of those videos, and remember to go in and do the survey for each of those Padlets in Blackboard. So, and again, your total grade is going to be out of 1,200 points. So, so it's really kind of what you're shooting for. That getting up close to that number. The syllabus has the grade range. So, so anyway, exam. I mean, again, you can go back and retake exam 1 if you wanted to. So, whatever. So it's up to you. Everything's available until Monday night into Tuesday, April 26th. So that's coming quick. I told you a while ago it would be coming quick. Now it's upon us. It's about 18 days away. All right, so case study 9, I know we've entered into the last module. Before I get into the case studies, this is the beginning of module 4, which is going to be let's see, so be 10, 11, units 10, 11, and 12. So we'll do some digestion, we'll do pH, and then we'll do a little bit with reproductive and genetics. Before we get into those, I did not do a video for unit 9 case studies or PhysioEx, so I want to do those here, even though that is module 3. Most of you have already done what you needed to do for these, but I do want to discuss those anyway. So anyway, I'm going to do 9, 10, 11, and 12 case studies, and then we'll do the PhysioExes. So the first one that we have is the cross-country collision. So we've got Hannah running in a cross-country race, and Myra looking for Hannah. She has to be around here somewhere. Myra's the mom, of course. Screaming encouragement, etc. But anyway, we've got an issue. So there are EMTs. A deer ran into one of the runners, and that runner happened to be Hannah. So anyway, EMTs explain a little bit about what's going on. We've got a cervical collar going and strapped in. So anyway, you can read all of that on your own. And this is a kind of based on somewhat of a true event. So, so anyway, I think there's a YouTube. There might be a short YouTube link that I put in here. But anyway, you can type in cross-country runner deer, I think, into YouTube, and it's about a 15-second video. So anyway, the first question just wants to know what do we think happened? Maybe some of these injuries sounds pretty dramatic. We've got cervical collars, we've got EMTs, we've got rushing to the hospital. So what is going on with Hannah? It could be any number of things. So we've got certainly fractured ribs or other bones, potentially punctured lungs or lung, pneumothorax, which kind of this whole case study is about. We could have a concussion. We could have some cuts, bruising. Anyway, there's a whole number of items. So, so anyway, we go through. We get her to the emergency department. Trauma case arriving in 10 minutes, double check supplies, listen to the EMTs. So now we made it. Hit by a deer while running, BP 100/80, 108, pulse 23 breaths per minute. Sucking chest wound, chest seal applied in the field. So anyway, that goes back to part 1. No signs of tension pneumothorax, minor lacerations, contusions, hit by what? So anyway, we go through some breathing and find the wound all the way through the chest wall. Yeah, it's not comfortable, certainly. Don't feel any obvious punctures to the lung. et cetera, and so forth. So ask what pneumothorax is. So you could, I'm sure you research that or will research that. But remember the way the lungs and the ribs, the lungs aren't right up against the rib, right? They're in a pleural cavity. So we have some space between the lungs. Well, the lungs themselves are covered in what we call that visceral pleura, and then there's a parietal pleura, and then they're in that thoracic cavity, that serous membrane. So anyway, pneumothorax occurs when air enters into that pleural cavity between the visceral and parietal pleuras. They have what's called spontaneous pneumothorax, where air may be leaking from the lung itself, maybe something like emphysema, um, or some sort of bola kind of ruptures spontaneously. And then we have traumatic pneumothorax, some sort of a penetrating injury to the thoracic wall. And that what happens is atmospheric air enters into that pleural cavity. So there is pressure in that cavity that helps to keep the lungs inflated so they're not collapsing. All right. So we get a chest x-rays, normal chest x-ray, letter A, Hannah on letter B there. Dense objects, bones appear white, air-filled spaces black, lungs are mottled gray. Pneumothorax. All right. So is it on the right or left side? So let's look at like a normal lung. You can see kind of all of this kind of webbing appearance here. Okay, so these are all the bronchioles kind of branching off of these bronchi. Okay. So it's normal lung. Okay. Then we go over to B. We can see there's a major difference in A and B. So now notice so this would be the right lung, this would be the left lung. And again, notice the left side of the heart taking up more room. So we have a smaller left lung than right lung. So we're looking at an anterior view, frontal view. Okay, so you can see the bronchioles and branches. Over here, we don't see, so the air is filling those. Over here in the right lung, we don't see anything. We do see this line right here. Okay. It's a diaphragm, likely, down here, or the bottom inferior edge of the lung. But yeah, this is probably the edge of the lung. Instead of it being out here, it's all the way in here. And notice we don't see any air going into this lung. Okay, so that's what we see over with the white. So let me move over. You can see quite a difference there. Normal lungs. And we've got a pneumothorax. Okay, so on the right side, there's black, right? There's no gray modeling going on. The edge of the collapsed lung is its line here, kind of dark space around it. Okay. Let's see what else. I think that's it for that question. So anyway, will the pneumothorax spread to affect the other lung? No, not likely. The right pleural cavity and the left pleural cavity don't communicate and are not connected with one another. For maybe, it helps, right, in a situation like this. Oops, sorry about that. Let's see. Food factors that keep the lung inflated against the thoracic wall. Let's see. Well, we've got pressure, of course, right? The intrapleural pressure. So the pressure inside that pleural cavity. it's about 4 millimeters of mercury of pressure, less than the pressure in the alveoli of the lungs. So there is a pressure gradient. That pressure gradient is what keeps the lung expanded against the thoracic wall. And because again, pressure is going to move from higher to lower. So it's lower pressure in that pleural space than in the alveoli. So the lungs naturally are going to kind of push against that pleural, where that pleural intrapleural cavity is. So if we breach that intrapleural cavity and it's exposed to the outside atmosphere, then the pressure is now greater, so the lung doesn't have anything to push up against. So now you have again, so the air pressure is going from higher to lower. So it's coming in from the atmosphere through the puncture and causing the lung to then deflate. All right. So anyway, pressure in the pleural cavity helps to keep the lungs inflated. The presence of the pleural fluid also helps out as well. And we have a surfactant too within the lungs, kind of in between and around the alveoli. Okay, but that helps a little bit. But that fluid in the pleura, so we have intrapleural fluid, and then we have that intrapleural pressure. The lungs themselves are made up of a lot of elastic fibers, so that helps with recoil and deflation when the lungs are expelling air. Okay. But again, the lungs generally are going to remain inflated against the thoracic wall due to that intrapleural pressure and the presence of that pleural fluid. Yeah, it helps that pleural fluid is kind of sticky. It allows that visceral pleura to stick to the parietal pleura. It allows for that surface tension to occur. So it minimizes the ability of the lung to kind of pull away from. So you've got the lung here, and then out here you've got the parietal pleura, and then surrounding the lung is that visceral pleura. So in between those, there's a fluid, and that fluid is kind of pulling that parietal pleura and then the visceral pleura in the lung kind of close together. So it's kind of like a suction going on. So it doesn't allow the lung to just pull away and deflate. Okay. Let's see. So that again, that number 4, B goes in then to how pneumothorax occurs and how it, how Hannah's lung deflated. So that pneumothorax again is so we've got a puncture from the outside. It's going to cause, so we're going through that parietal pleura, and so we're disrupting now the pressure gradient. So the intrapleural pressure is no longer less than the pressure inside of the lungs. So, okay. Remember, pressure moves from high pressure to low pressure. So so now we've got higher pressure pushing against the lungs. Okay. So air is entering the pleural cavity from the atmosphere, right, through her wound. So once that intrapleural pressure is now exceeding the pressure inside of the lungs, we call that intrapulmonary. Remember, intra, I-N-T-R-A, as a prefix means inside of, right, like intracellular. Okay, so the intrapulmonary pressure is now less than the intrapleural pressure. And so, and then again, the fluid is not there either. So now we've got the recoil, the elastic recoil causes it to pull away from the pleura and collapse. Okay. So hope that makes sense. I think there are a couple videos as well. The Padlet, you'll want to check that as well. You just type in pneumothorax into YouTube if you're still kind of unsure what's going on. All right, so number 5, adhesive seal is removed. Why did Brent hear a sucking sound each time Hannah inhaled? What can you conclude about the pressure gradient between the atmosphere and the pleural cavity? So again, we've been through this a few times, so we'll keep going with it. Well, first of all, that sound is the result of air being drawn into that pleural cavity past the edges of the wound. If air is flowing into the pleural cavity when she inhales, the intrapleural pressure must be lower than the atmospheric pressure. As she expands her rib cage, as she breathes in, the intrapleural volume increased, which resulted in reduced intrapleural pressure. Okay, so intrapleural. So remember, pressure and volume are inverse. So the intrapleural volume increased, right? So air came into that intrapleural space or cavity, and that reduced the intrapleural pressure. Okay. Once we took that bandage off. Okay, tube in the chest, can't breathe. Yeah, so you go through that as well. Seal across the wound, sucking sound stops. Quickly retrieve the tracheostomy, okay, thoracostomy, I should say. Why will Hannah's lung not reinflate on its own when she inhales? Okay. Her lung's not in contact with the thoracic wall. So even though the wall's moving, it doesn't result in the volume of the lung increasing. And if the lung volume doesn't change, the pressure inside the lung isn't going to decrease. So remember, as the lungs inflate, then the volume's increasing, but the pressure's decreasing. Okay, so her lungs are unable to, we are unable to get an increase in lung volume, okay, because we have a puncture and the pressure of the atmosphere pushing into that intrapleural space is not allowing the lung to inflate. Okay. If the lung volume doesn't change, the intrapulmonary pressure isn't going to change either. Never going to go below atmospheric pressure, and that's how air moves into the lungs. Okay. Remember, air moves from high pressure to low pressure. So as once the lungs get below atmospheric pressure, okay, so 1 atm or 760 millimeters of mercury. Once we get below that pressure, okay, then air is going to just go right into the lungs. Okay, so the lungs inflate, and the diaphragm pulls the lungs down, the thoracic cage expands. That causes the volumes of the lungs to increase and the pressure inside the lungs to decrease. Once that pressure gets below atmospheric pressure, then air is going to move into the lungs. That's under normal conditions, right? Well, with a pneumothorax, again, the lung is no longer in contact with the thoracic wall. So as the thoracic wall expands, as the diaphragm pulls down, the lung isn't attached to the pleura anymore. So so the volume of the lung isn't going to increase. So the pressure is not going to decrease below atmospheric pressure. So air is going to be unable to go in. So that's the pressure gradient. Now the number 2, the insertion of the chest tube allows air to be removed from the pleural cavity. Okay, so the chest tube is like a vacuum. It's going to pull that air that's in that pleural cavity out, and it's going to reduce intrapleural pressure. So once we get that intrapleural pressure to go below the pressure inside the lungs, remember, normally it's about 4 millimeters of mercury below the intrapleurals, but lower normally. So that again allows the movement of the lungs and allows the lungs to expand. So anyway, we put the vacuum tube in, pull that air out, and once the pressure gets in there, it gets below the pressure in the lungs, the lung will then inflate. Okay. And it'll make contact then with the parietal pleura again. Okay. Assuming again that the chest tube is the only exit for the air to leave the pleural cavity, and that air can't leave in any other location. So if we just, so it's assuming we have one puncture. So in the chest tube, we're going to go into that puncture. So once we put the chest tube in and vacuuming that air out, whoop, and then we can air can it or in any other location. We seal the wound, it'll repair itself, and there'll be a seal between the thoracic wall and the chest tube. So let's see, why did we avoid putting the chest tube below the fifth intercostal space? Well, that the diaphragm can rise as high as the fifth intercostal space. So if we put a chest tube inferior to the space, that increases the risk that we could perforate the diaphragm and then cause injury to abdominal organs. Let's see, 2C, chest tube also requires careful placement within the intercostal space to avoid significant bleeding. Review the blood supply thoracic wall on the diagram, draw a line in the oh wait, I don't think I have you do that. Let me go over to the questions here. That doesn't sound like something I needed you to do. 3C, no, I think we're done. Tension pneumothorax. Wait. Oh, here's why did avoid putting, how is a tension? Oh, and then number 3. So anyway, yeah, there is no 2C. So sorry about that. I was gonna say, I don't remember I'm having to draw. So anyway, 3, A, B, and C. Tension pneumothorax, different than typical pneumothorax. Again, in a typical or simple pneumothorax, air is going to enter the pleural cavity and the negative intrapleural pressure is lost. So what that causes the lung to partially or completely collapse and interfere with ventilation. So the amount of air in the pleural cavity is relatively constant. So but in a tension pneumothorax, air continues to enter the pleural cavity with each breath out, but it cannot escape. So the increasing volume and pressure shifts the mediastinum to the opposite side and disrupts not only ventilation, but can affect the heart function as well. So typical pneumothorax isn't usually fatal, but a tension pneumothorax almost always is, unless it's immediately treated. So, so anyway, this is a typical pneumothorax, not a tension pneumothorax. Okay. Chest tube inserted. Chest tube sure that hand doesn't develop a tension pneumothorax. Position of the heart compared to normal X-ray review. Cardiovascular structures play a significantly increased volume and pressure in the pleural cavity could affect those structures to produce hypotension. So the increased pressure and expansion of the pleural cavity lead to compression of the superior and inferior vena cava. So again, we're looking at the right side of the right lung, which reduces venous return to the heart, and then thus we're going to get lower cardiac output and thus lower blood pressure. So the atria could also be compressed, which certainly would further impair cardiac function. So tension pneumothorax can be fatal if not treated quickly. What would you do if you did not have a chest tube available or did not have time to insert one? Well, we have to remove the air immediately to reduce pressure in the thoracic cavity. So Any any type of large bore needle or puncturing device can be inserted into like the second intercostal space to allow air to escape. First responders will use that certainly before they get to the hospital setting. Let's see. So again, some sort of incision or puncture, manipulating the wound edges so that they remain open during exhalation is going to be another alternative. Okay. All right. So let's see. Let's go to the next one. Cannibal. Now this one is a little bit, this one we do in class. So some of the way the questions are worded may seem a little weird, so I'll explain that. There's a couple ways of approaching this. So typically we do this kind of like I say in a group setting. So you'd work in groups, and each group would have a different energy drink, and each group would analyze the ingredients, and then we'd all kind of come together and chart those out in a table. So anyway, so you're kind of doing it on your own. So um, you can analyze just one drink throughout. You can kind of look through and look at all of them collectively, and look at some of the consistent ingredients as you're listing your ingredients. That's what I prefer, really, is that you analyze all of the beverages and kind of look at some of the common ingredients and put those into your table. So we'll look at that in a few minutes. So anyway, we're looking at different energy drinks. You can again go through and read this on your own. There's certainly marketing claims. This is big business, right? The energy drinks. I'm sure some of you consume energy drinks to a certain degree. I mean, honey and water is is an energy drink of sorts, right? Kool-Aid is an energy drink of sorts. So, right. I mean, if it's got sugar in it, it's going to have or some sort of glucose or carb. It's going to have energy, right, by definition. But most of us think of energy drinks as like Red Bull and Propel and I don't know, whatever else. There's a zillion of them out there. I mean, you go to the just go to a gas station, and there's at least one whole cooler bay, if not a couple of them, full of a variety of energy drinks. So anyway, believe it or not, in all my years of 40, almost 46 years, I've never had an energy drink. I've had one. I bought a 5-hour energy. I think it was like raspberry or something, strawberry maybe. Uh, 10 years ago on a road trip. We had about 3 or 4 hours to go at the end of about an 18-hour drive. And so anyway, I stopped and got gas. I was like, we got about 3 or 4 hours. It's a 5-hour energy. I didn't really want a soda for whatever reason, or a pop, a Coke. So I just bought one and oh man, it tasted horrible. I'm sure it had aspartame or some sucralose or something that's just disgusting, some artificial sweetener. But yeah, it didn't. I think it did, because I can taste that from a mile away. I can almost smell it when But yeah. So yeah, that it's kind of didn't have very good taste. But anyway, that's the only time I've ever had any type of classified energy drink. So I'm really not even sure if I ever would want to. I drink some tea. I have a soda every now and again, but yeah. Anyway, go through these. I don't have a dog in the fight, I guess is what I'm saying. I don't promote them. I don't think they're a good idea, but at the same time, I mean, a lot of things that aren't good for you. So yeah, a lot of things that are. But anyway, you can read through some of this info, and Charlie's got a list of questions about some of these, about energy and what it all means. And then, yeah, here we go. We've got the ingredient list for you so you can go through. We even got Coca-Cola in there too, so you can compare those later. So anyway, it gives a little bit of the biochemical information. So go through and look at this list. I mean, this is a great, a very informative case study on ingredients, and I encourage you to do this with pretty much anything that you consume if you have the time. Just go up into your pantry or your cupboards and pull out a box of Cheez-Its, or pull out a can of soup, or whatever the heck it might be, or bottle of soda from the fridge. Check out the ingredients. A thing of Oreos, yum. You know, then you can when you're at the store too, if you've got options with like different chips, or which you will, right, to generic options, all the way up to multiple different name brands, same with cookies, same with pretty much everything, right? So compare pancake batter, even compare and contrast some of these ingredients. A lot of the price points on some of these name brand items being higher than the generic, or whatever, I guess, yeah, generic name items or store brand items, right? Walmart brand or Kroger brand or Piggly Wiggly brand, or which is, I don't remember what their brand, but anyway, you're right, they all have their own kind of store brand. It's more inexpensive, right, than the name brand. And a big reason for that is some of these extra ingredients, these different preservatives, different sweeteners, particularly. So, look at the ingredients. If you've got, a box of, whatever it is, wheat thins, and the Nabisco brand, and then you've got the Great Value wheat thins. Take a peek, see if you notice any differences. Maybe you will, maybe you won't. Some stuff there isn't really any difference. So there might be some flavorings. It's the other thing too, right? About a lot of these ingredients lists, you don't get to see the flavors, the specifics. It just says natural flavors or artificial flavors. So that gets tricky. But anyway, you can read through some of this. We'll read through all of it. It's very good info. Anyway, full of, I mean, we offer a nutrition course. So it's an elective. It's, I think, fully online. I think Lori Janice, who teaches microbiology in Burlington, I think she teaches a little nutrition course. So you'd go through something like this potentially in that class. But anyway, so I want to clear up a couple of things that, kind of what I'm looking for with this. So part one, what is the nature of each ingredient listed on the cans? Well, when you look at this table, it kind of has number one there organized for you. So I think what you can do is probably put several of these, if not all of the ingredients that you find on these different energy drinks, you could put them under these different columns. So let's see, I think I've got let's see. So source of it of energy. So these are going to be like your carbohydrates, right? So hopefully that's what you leave in there. Those are your true sources of energy. So anything with sucrose, which is white granulated sugar. Well, oftentimes it's granulated, but it's what you think of as your kind of your regular cane sugar. Or beet sugar, fructose, and glucose. So those are the main sources of energy you'd probably see listed on these different energy drinks. And then amino acids, there's a few of those. Those usually, so the remember the source of energy are carbs. So those are going to generally be OSE at the end. Now, not always, right? Like sucralose is an artificial sweetener. So that's going to go over in this column. it does end in an OSE, but it's not a source of energy, nor is it a carbohydrate. So you can't always go exclusively on that OSE equals a source of energy or a carbohydrate. So keep that in mind. Not all these rules aren't hard and fast and always and nevers, right? So a lot of them are most of the times, though. So most of the time, a carbohydrate source of energy is going to end in an OSE. Not always. Amino acids generally are going to end in an INE. So we see like taurine, glutamine, lysine on some of these. Okay, so those are going to be your amino acids. Then your stimulants, vitamins, coenzymes. So, like caffeine is a big one, right? In there. And then there's some vitamins, right? So like folic acid and niacin. So anyway, there's a whole list of different stimulants, vitamins, coenzymes that you could put there. And then artificial sweeteners, preservatives, asulfame, potassium, aspartame, sucralose, potassium sorbate, citric acid. Anyway, there were others, and like drawing a blank, but you can fill that chart up. That would take care of part of number one, really, for that. So again, which ingredients provide energy? I just mentioned those. You want to think the carbohydrate-based ones. Which ingredients provide body repair? So we're thinking of the proteins or the amino acids, right? Like taurine, which remember too with amino acids, or maybe you don't know this, there are roughly 20 amino acids and half of them are non-essential. So you don't need to consume them. Your body recycles protein. So 10 out of 20 amino acids are recyclable. Taurine, which is one of the 20 amino acids, is a non-essential amino acid. So you don't really need taurine. You produce taurine or you recycle taurine in your body. So, so anyway, so keep that in mind too. If taurine is going to help build my, I mean, I suppose if you're working out a lot and you're pumping a lot of iron and you need a lot of protein and muscle rebuilding going on and repair going on, then sure, there may be certain chronic wasting, or not chronic, like muscle wasting diseases where we have protein malfunctions and we're wasting, giving muscle wasting away or atrophying. So we need to bump up amino acids, maybe taurine boost. But again, it's a non-essential amino acid. So let's see, part 3. So kind of question 1 and then part 2, fill out the table. They kind of part and parcel, I suppose. All right, so what else are we doing? It gives us energy. What does that mean? Kind of the biological definition of energy. So again, we're thinking of breaking bonds, right? So we break bonds. That's how energy is released, right? We don't create energy. Energy gets released when bonds are broken. And that can be recaptured in the bonds of ATP or energy management molecules like NADH or FADH through glycolysis, the Krebs cycle, oxidative phosphorylation, okay, the electron transport chains, right? So, so we're thinking cellular respiration. That's and glucose and oxygen are the big players in that. Fructose and galactose as well. Monosaccharides, simple sugars. Again, glucose is the preferred source. Physiological role of each of the molecules in our table, what provide energy. I mean, we've kind of been talking about this. So some of these may seem a little bit redundant. Body repair. So physiological role. So maybe a little bit of so cellular respiration for energy, protein synthesis for some of the body repair. Okay. Let's see. What ways might the one or that does or do does not have metabolic energy source, caffeine, provide the perception of increased energy after consumption? Um, so, in what ways might the ones that do not have a metabolic energy source, caffeine, for instance, provide the perception of increased energy after consumption? Um, Caffeine is a stimulant because it's an antagonist of adenosine. So remember, adenosine is what we call a nucleotide. It's the what makes up ATP, right? Adenosine triphosphate. So the nucleotide adenosine is kind of like a depressant neurotransmitter in the central nervous system. So what caffeine does is it antagonizes adenosine. So so caffeine providing energy is a little bit misleading. It blocks depressant neurotransmitters. So I guess in that way it provides energy, but it really isn't providing biological energy. So anyway, how are these ingredients helpful to someone expanding or expending a lot of energy? For example, a runner. Certainly, runners they're expending a lot more energy, using up a lot more ATP. So simple sugars, complex carbs, right? Your starches, your pastas, all of that uh, before the big workout. Not right before, but leading up to, right? And then build the various amino acids, providing, building blocks as well. Um, so anyway, I think that we're kind of building some redundancy a little bit here with some of this. But again, the more you see it, the more you look at it and discuss it, I think the more it makes sense. Does your analysis substantiate the claim that any of these are, in fact, energy drinks? If so, what molecules are the sources of energy? Again, that's up to you. You can decide subjective opinion, what you think based on a little bit more info of what you know. Maybe put something in there before you did this and kind of went through this, and then now what do you think of it? You know, so eh, could your drink serve different? Could any of these drinks serve different purposes for different consumers? So, yeah, sure, right? I mean, some athletes, not just athletes, them too, but like people who work out or expend a lot of energy. Certain jobs require a whole bunch of energy, and not just physical energy, but brain energy, and the brain does use up a lot of sugar. So, I mean, yeah, some of these do provide different sources of actual sugars, good sugars. Some of them have good amounts of essential amino acids as well that could help with tissue repair. Um, some of those boosts in energy that we get from caffeine, you know, may help. Some of them have essential vitamins and minerals in them too, right? So, I mean, you know, caffeine, probably not necessary. You could go with honey or something like that. What's a normal physiological response to increase intake of sugars, to increase intake of caffeine. So excess amounts of sugar get stored as glycogen, right? And caffeine in the liver. Caffeine, again, I think we've kind of talked about what that can do. And again, it blocks those depressant receptors, and um, but excess amount of caffeine. Some folks will say that it actually knocks them out, makes them more tired. Let's see, is there such a thing as a sugar high? I don't know. Maybe it's probably more. Yeah, I mean, to a degree, it's like there's a physiological response to mobilizing all of that glycogen that your body converts. If you consume a ton of sugar and you're not using it all right away for energy, you're going to again mobilize that it's glycogen and fat to fuel metabolism when simple sugars aren't available. So excess simple sugars get converted to glycogen and fat. So when you don't have energy, you can convert the glycogen and fat into energy. So if you eat excess simple sugars, you're going to have excess glycogen, and the liver stores glycogen, but it only can store a certain amount of glycogen. I think I don't know, 70 grams or so. I don't think it's a lot. So the rest, once you hit the kind of full level in the liver for glycogen storage, then you'll convert to fat. Um, so so anyway, you got to eat right too, right? I mean, that's so anyway. Evaluate in terms of basic physiology and biochemistry. Lack of sleep causes lack of energy. So evaluate that. Well, not the lack of energy may come from your inability to metabolize glycogen to produce ATP. So you may feel a lack of energy. High energy, you're feeling more spunky. Low energy, not so much. At the metabolic level, the body is pretty much supplying a homeostatic supply of energy all of the time. So the lack of energy, again, there may be some metabolic issues going on with your ability to metabolize sugars uh, uh, into glycogen and fat, or from glycogen and fat to produce ATP. So um, the product claims legitimate. Maybe. I mean, again, it varies. Some energy terms are more subjective. Should you simply buy a can of Coke? So here's where the can of Coke comes up. Should you simply buy a can of Coke rather than one of these energy drinks? Why or why not? So um, maybe. I mean, if it's a little lot cheaper, right? A can of Coke. Well, I don't. Yeah, maybe. I mean, it used to be get a can of Coke for 50 cents. Now, I don't know, probably a buck or more. But a fountain Coke, right? Those are a lot cheaper, maybe than an energy drink or a Red Bull. So you're gonna get if you're just drinking the Red Bull for caffeine and sugar. I mean, you can get Coke is definitely going to be a lot cheaper. So everything else, I mean, kind of questionable. um I mean, obviously, if some of them have different vitamins and minerals, you're not going to get that from the Coca-Cola. Then it says got to, it should say go to. Oops, gotta. Oops, I'll fix that. Okay, go to benefits of honey energy drink. Read to the website and just discuss a little bit about what you think about honey as an energy source. All right, so let's go to the next one. Case study 11. Oops. Unusual case of hypertension. So, Mr. Smith, 50-year-old, otherwise healthy white male, no signs or symptoms of acute distress, very busy, popular restaurant, active lifestyle, no history of smoking, a little bit of wine. Why his blood pressure is higher despite the fact he takes good care of himself, no family history, appointment, I mean, 190 over 110, heart rate of 90. Holy cannoli. Everything else looks good though. Return to the clinic. Additional pressure measurements. Subsequent readings were comparable with the initial elevated levels. No other remarkable findings. Recommended with the active, healthy lifestyle, monitoring his diet. Prescribed thiazide, potassium sparing thiazide diuretic, 12.5 milligrams orally once a day in order to help manage elevated blood pressure. It was very compliant with his treatment. All right. So, first off, a little bit of a blood pressure discussion. So, what's normal blood pressure, normal values? What are some risk factors of hypertension, lifestyle change recommendations? So, I think you can, for target organs used to treat hypertension, certainly we're going to go look at the heart, the blood vessels, kidneys, lungs. Those are the big four, right? When we're dealing with blood pressure. So we could have a kidney issue, we could have a heart issue, we could have blood vessel issues, and we can have lung issues. So when we have a patient that presents us with hypertension, those are the four organs we're thinking about. We're thinking about the heart, really the cardiovascular system. That's the heart and blood vessels. And really the blood to go along with that, of course. And then we're thinking of the lungs and the respiratory system, and then of course the kidneys and the associated hormones and adrenal glands with the kidneys, such as the adrenals. So anyway, major categories of pharmacological agents. Again, thiazide diuretics, so ACE inhibitors. We can get some angiotensin receptor blockers, calcium channel blockers. Um, anyway, those are we usually start with the water pills, right? The thiazides. So let's see. For the next 2 years, follow-up period, Mr. Smith's asymptomatic hypertension persisted despite these attempts at monotherapy, followed by combination therapy using different pharmacological agents. All medications gradually introduced by the physician one at a time, orderly increments. In addition to that initial thiazide diuretic, now at a double the dose 2 years later. Latest regimen includes enalapril, an ACE inhibitor, 20 milligrams, and amlodipine, a calcium channel blocker, at 10 milligrams a day. So, the restaurant expanded, working managing its larger, more successful business, blood pressure still elevated, gradually recurring headaches, frequent urination, thirstier than usual, suspects diabetes, returns to the doctor, doctor performs blood work, physical exam, which reveals blood pressure for 145 over 85. That's better than he was, right? 190 over 110. Heart rate of 80, mild peripheral edema. Results from the blood showed his blood glucose levels were normal. Renal function, though, were borderline high. Potassium level slightly low. To add a medication, K-Dur, potassium supplement, 10 milliequivalents orally twice a day. With diabetes ruled out, doctor made the recommendation, Mr. Smith, to continue with the current medication, put him on a low sodium, low cholesterol diet, follow-up visits in 3 months intervals, corresponding lab work, remained relatively stable with minimal change when compared to previous parameters. So this is a very typical case, right? We see this is, I mean, kind of the bread and butter of the clinic, right? What's going on at the clinic and what a high percentage of our patients, how they're treated for hypertension. All right. So let's see. How do diuretics, ACE inhibitors, angiotensin receptor blockers, how do they help to treat hypertension? Well, again, diuretics are going to decrease the volume overload because they increase urine output. So we can decrease the amount of volume overload on the kidneys, and osmotic pressure and hydrostatic pressure hopefully will go down. He did a little bit, right, with this guy's case over 2 years period of time. AC inhibitors, again, they decrease the activity of angiotensin converting enzyme. That's what it means, right? ACE means angiotensin. Angiotensin is a chemical that causes vasoconstriction. let's see there. But so an AC inhibitor blocks the conversion of angiotensin 1 to angiotensin 2. So that will result in vasodilation and a decrease in blood pressure. So if ACE or angiotensin converting enzymes causes constriction of blood vessels and increase in blood pressure, if we can inhibit that from happening, maybe we can decrease blood pressure. So the other thing we can try is angiotensin receptor blockers, which are going to block the angiotensin 2 receptor. So the angiotensin can't finish what it started. So blocks the effects at the sites, different from the ACE inhibitors causing vasodilation. Same things happening here, right? Calcium channel blockers was the other one. Blocks the voltage gated calcium channels in the heart muscle as well as blood vessels. That results in a decrease in cardiac contractility as well as then vasodilation in blood vessels. So heart isn't going to beat as hard, and blood vessels are going to be more dilated. Hormones that regulate sodium and potassium levels, right? We've gone through this at this point in the semester. We should have a pretty good grasp on what regulates sodium and potassium levels in the body, right? Aldosterone, again, increases sodium reabsorption and potassium excretion at the kidney level. Okay, so we're gonna reabsorb sodium, which then causes water to be reabsorbed, retained, and then potassium to leave, right? Let's see. What else are we looking at? Anti-diuretic hormone increases water reabsorption by the kidneys. Atrial natriuretic peptide, so coming from the heart, right? Or ANH, we'll sometimes hear it. So we have ADH and ANH. It's created by the atrial cells of the heart, dilates the juxtamedullary afferent arterioles at the kidney, at the glomerulus, right? So the afferent arterioles of the kidneys get dilated, to causing vasodilation of the systemic blood vessels and decreasing aldosterone levels by the adrenal glands. So remember, aldosterone is going to cause you to retain water. You retain sodium, retain water, you get rid of potassium. So this patient's potassium levels were low. So they're eliminating excess amount of potassium. That means they're maybe keeping excess amounts of sodium. That means they may have an aldosterone issue. Aldosterone levels are too high. So anyhow, and that comes from the adrenal glands too. So adrenal glands do a lot of this work to help to maintain water and fluid balance, as well as electrolyte balance, right? Sodium and potassium, calcium. So those are your stress organs as well. So usually hypertension equals stress coping mechanism problems. Again, sleep issues. This guy sounds to me like he probably has a lot of money, so therefore he has a lot of problems, right? So including health. Anyway, why did the doctor advise a diet low in sodium? Again, we're not going to accumulate as much fluid, right? If we're not eating as much. Remember, water follows sodium. There's one thing you should have learned by now in this class, and hopefully it's that water chases sodium around. So if we have too much sodium in the body, we're going to retain potentially too much fluid, especially as we get older, because the kidneys will help to kind of keep us in homeostasis with that. And if the kidneys can't do it, then anyway, then we're going to retain a lot of water. And too much fluid means more pressure, right? Blood pressure increases. Cholesterol, again, is going to help with decreasing the buildup of saturated fats. It's going to keep the diameter of those blood vessels from being too small due to the buildup of cholesterol. All right, recurring headaches. Again, he's got water overload. He's retaining too much water. He's got vasocongestion basically going on. Increased vasodilation, increased vasocongestion then in the brain. Let's see, polyuria and polydipsia. So he's peeing a lot. Probably well, he's got water overload, so his aldosterone levels are up or are high. So that means his sodium levels are high, potassium levels are low. So that, again, he's got fluid overload, it sounds like. Well, that increased water load causing increased urination. Plus, that's compounded by the thiazide diuretics that the guy is on too. There's further loss of water. So this guy's peeing. It's a battle, right? He's kidneys and his adrenal glands, his heart. They're all saying, hey, hold on to water, hold on to sodium. He's on pill, and his hormones are doing that. He's got pills that are saying, no, get rid of water, get rid of water. So he's got a lot of yo-yo going on here. Elevated serum sodium levels. So his thirst centers. So polydipsia means he's thirsty all the time. So thirst and water consumption needs those are stimulated. That's in the hypothalamus. So when we have elevated sodium levels in the blood serum, in the plasma of the blood, it's going to trigger that's the stimulus in the blood, elevated sodium. The response is to get that hypothalamus thinking about drying the mouth, to getting the brain thinking about drinking water. So we can dilute that excess sodium that's in the blood because he's peeing it out, or he's peeing out all this water because of the thiazide diuretic. His aldosterone levels are high. That's going to cause him to pee more. So he's losing water. He's dehydrated, but yet he's retaining sodium and thus retaining water. He doesn't have enough water because he's peeing it out. So he's thirsty all the time trying to drink it. Again, this is a very common theme we see in the clinic. Anyway, part 3, 1 year later. About a year later, suddenly began experiencing increasing muscle weakness, cramping, tingling, palpitations, generalized fatigue, recurrent headaches. One day he felt very uneasy, asked his coworkers to take him to the emergency room. Physical examination, and the only significant findings were blood pressure of 210 over 120. Oh, that's the only thing wrong with him. All right, well, heart rate of 110 and moderate peripheral edema. Rest of the ER revealed the following. So sodium levels slightly high, potassium levels slightly low, chloride levels at the high end of normal, which we would see if sodium's high, chloride's going to be high, and they're barely high. Carbon dioxide levels, his are low. Blood urea nitrogen is high. Creatinine is high. Glucose is right where it's supposed to be. Magnesium maybe a little bit low. So let's see. Additional routine tests, which included a complete blood count, chest x-ray, 12-lead EKG, all unremarkable. An arterial blood gas analysis consistent with a mild metabolic alkalosis with some degree of compensation. Okay. So he's got decreased CO2. So that's an alkalosis problem, not acidosis, because remember, excess CO2 is an acidic problem. Let's see. An abdominal ultrasound revealed a suspicious small mass at the level of the right adrenal cortex. Further imaging, evaluation, high resolution CT scan confirmed an adrenal adenoma. So we have a little cancer, a little tumor on the adrenal gland, the right adrenal cortex. Okay, the right adrenal cortex. Based on the CT scan, he underwent surgery, removed the adrenal tumor. Post-op, he recovered well. Significant improvement. Blood pressure began to normalize gradually after just a few weeks. Doctor was able to completely discontinue all blood pressure measures, no further complications. 3 years it took to figure this out, right? Now, did he have this adenoma 3 years ago? I don't know. We may never know. What's the proper name for this medical diagnosis? Proper medical diagnostic name for this condition is primary hyperaldosteroneism due to an adrenal adenoma. They call it CONS, oddly enough, right? With 2 N's, though. CONNS syndrome, right? CONS syndrome. Uh, that sounds like, right? Adrenal adenoma, idiopathic hyperaldosteroneism, abnormal gland overactivity, possibly bilateral, so both sides, idiopathic adrenal hyperplasia, maybe abnormal growth of both glands. Almost 70% of cases when we have hyperaldosteroneism, so too much aldosterone. Why would you have too much aldosterone? Is the brain saying we need more aldosterone? Maybe over time, the brain may be getting those signals, right? Because we've got sodium and potassium levels and water levels we need to balance out. Remember, aldosterone eliminates potassium and retains sodium and thus retains water. So if we have a chronic dehydration issue, then one of the ways the body responds to chronic dehydration or systemic dehydration is to retain sodium. And how do we retain sodium? Well, we eliminate potassium. So that's what aldosterone does. And the adrenal cortex produces that aldosterone. And so, again, if we have elevated levels of something, it's oftentimes because we have excess number of cells that are able to produce the extra amount of chemical. So I have extra aldosterone, maybe because I have extra cells that produce aldosterone. Does that make sense? Hopefully that makes sense, right? All right. So more cells, more aldosterone. What does excess cells mean in medical world? It usually means a tumor. Sometimes they're benign, right? They're encapsulated. Sometimes they're not. We try to find them when they are encapsulated and benign. But 3 years ago, this guy's, I don't know if he got his aldosterone levels checked. I thought so. But I mean, come on, if you see, we can treat it with a bunch of pills for 3 years. And it's not, lack of those pills isn't why this guy had elevated aldosterone levels, right? He had elevated aldosterone levels because either the brain isn't working right and it's telling his body, or the kidneys aren't functioning right. Well, they ran all those tests and said, oh, yeah, everything looks good. You got to look at the source. Where does aldosterone come from? The adrenal cortex, the adrenal gland. So maybe too much aldosterone is too many cells that produce the aldosterone. All right. So anyway, then it talks about renin-angiotensin aldosterone pathway. So again, the liver is the source of angiotensinogen, which gets converted to angiotensin. So whenever you have a gen on the end of something, it just means the precursor that's going to generate whatever it's talking about. So angiotensinogen is the precursor in the liver to producing angiotensin 1 by the action of Renin. All right, and renin's a kidney hormone. The stimulus for renin release comes from the juxtaglomerular apparatus. It's a decrease in renal perfusion. Once renal perfusion is decreased, angiotensin 1 gets triggered and gets modified into renin gets released, and then that's going to trigger angiotensin 1 to get modified to angiotensin 2 by the presence of angiotensin converting enzyme, right? ACE. And that comes from the lung capillaries. So this is where COVID is a problem, right? ACE is getting triggered in the lung capillaries, and it's causing almost like an autoimmune response to too much inflammation and too much fluid buildup, because the body's response whenever we have excess amount of ACE is that there must be an emergency. There must be an increase in blood pressure, an increase in heart rate. There's inflammation, so maybe there's an emergency. So angiotensin 2, in addition to being a vasoconstrictor, also stimulates the adrenal glands, adrenal cortex specifically, to produce aldosterone. And then aldosterone promotes sodium reabsorption, potassium secretion. So if someone has excess amounts of aldosterone being pumped, it could be a liver problem, maybe angiotensinogen, right all the way at the beginning. That could be where the issue is. We could have a renin problem. So a kidney issue. There could be something going on with how the kidney's release of renin takes place. Right? Angiotensin. We could have a respiratory ACE issue that's gone mad. ACE has gone rogue due to some sort of viral infection, due to some sort of protein mutation, misfolding, something leading to ACE being in excess. Okay. And that excess, so chronic inflammation potentially. Okay. Angiotensin, right? So vasoconstriction, blood pressure, increasing the amount of constriction. Okay? These are vasoconstrictors. This is normal under stressful situations. And the lung capillaries, where we're going to find that ACE. Okay? And again, that's going to trigger aldosterone. And why does stress and inflammation and all this ACE causing vasoconstriction to go on and blood pressure then to go up? Again, that's normal, right? If the bear's chasing you, because we need all of these to be vasoconstricted. And then we need all of these arm appendage blood vessels, head blood vessels. We need those to be vasodilated. So when we talk about vasoconstriction, we're talking under stress, we're talking about that happening in a central location within the cardiovascular center, within the pulmonary centers, within the kidney centers, okay, within the the trunk, right? So because under stress, it's the arms and the legs and the head and the face and the eyes and the ears and the nose. That's what has to be on high alert. Okay. So when all of that's going on, there's a lot of inflammation. Right, the heart's beating faster. There's more constriction of the blood vessels here, more dilation out here. That's causing a lot of inflammation, just normally. It's a lot of friction. So the body needs to retain water in order to help with some of that, as well as to help with the blood viscosity. Right? If I'm pumping blood at a high rate because I'm under stress, I'm getting chased by the bear, it's better when that blood is thinner. So I want to retain water. I want to retain water to make my blood a little bit thinner. I want to retain water so it's easier to pump. I want to retain water to help with some of the the anti-inflammatory aspects that water can provide, putting out the fires. Hey, so how does your body retain water? It absorbs, reabsorbs, hangs on to as much sodium as it can from the kidneys. And aldosterone's a major player in that. So this is that cycle that we talk about, the RAAS, renin angiotensin, RAAS, renin angiotensin aldosterone system. Okay. Hyperaldosteroneism. So this guy, again, too much aldosterone. It can be asymptomatic. Again, generalized lethargy or lethargy, weakness, high blood pressure, headaches, too much sodium in the blood, not enough potassium in the blood. Okay. Not enough magnesium in the blood, muscle weakness. What's the pathophysiological process of this guy's symptoms? Let me go back over here. We go. Make sure we're doing all the right questions. Good. Increased sodium, decreased potassium. I mean, we've been through, I think by now you should be able to answer that one. Primary or secondary. So he has, his problem is primary hyperaldosteroneism. The blood pressure issue is due to the hyperaldosteroneism. So the blood pressure problem is hypertension is secondary, right? It's not primary. It's secondary hypertension. It's a response to the primary issue. Sometimes a patient has no issues whatsoever. They just, this guy kind of presented as having just a primary hypertension problem, right? He's under some stress. He's working a lot. He owns some businesses. Everything pretty much checked out initially. So yeah, we would probably assume, oh, this guy's just got primary hypertension. So that's what we do. We treat him for primary hypertension. We give him diuretics and some sort of thiazide, a water pill. Maybe a cholesterol drug, a statin to go with it, and hope that that's enough, and tell them to watch what they eat, and that's it. And we may see them occasionally for their annual review or whatever. Yeah. But in this situation, after 3 years of looking at this patient, we realized this wasn't a primary hypertension problem because the treatment protocol wasn't working. So we did some other stuff and isolated this as a primary. The primary issue was his excess amount of aldosterone being produced. And why is that? Because he probably had some sort of a tumor in his adrenal gland, the cortex of the adrenal glands, which we saw, right? The CT scan showed that. Anyway, what other important blood tests could be used to diagnose this condition? Well, we can look at his aldosterone and renin serum levels. So we would probably see elevated serum aldosterone and suppressed serum renin activity. That would be highly suggestive of hyperaldosteroneism. Salt load to find out if aldosterone secretion is non-suppressible and therefore just autonomous, just doing it on its own. Once that's established, with a CAT scan, MRI of the adrenals, just really kind of what we did, but go further maybe with that. Surgical therapy, right? We could do an adrenalectomy on him. I don't know. That's probably about it. I mean, I don't know if there's much of. There are non-selective aldosterone blockers. Aldactone is what one of them's called. There are selective aldosterone antagonists that have come out. I mean, this is a big problem. This has become an issue over the years, right? We see a lot of hypertension. Some of it's primary, some of it's secondary, and oftentimes it's an aldosterone issue. Um, so anyway, that's it. I think there's plenty of info you guys should be able to work through on that one. All right, let's take a peek at case study 12. So let's case study 11. Case study 12 is kind of a fun one. You could do this however you want to do it, but there's a Google Doc for it. You're going to go to what's called the NORD database. You can go there first, second, it doesn't matter. You can pick a disease out of there. I put an A to Z. Let me refresh this. It's kind of acting funny. There we go. Wasn't letting me, it wasn't highlighting my hyperlinks. So the A to Z randomizer, if you go there, it's automatically wrote, so it came up with a P. If you can click roll again, it came up with a D. It doesn't matter. You pick any letter you want. That's just a randomizer, kind of a fun little deal. And then you'd go to the NORD database. It's a rare disease database. Okay. National Organization for Rare Diseases. So you can see there's 0 through 9. There's just a 1 there, Klinefelters. But A through Z, so you spin we got a P, so then you can come over here, you click the P, and select any disease that you want from that list. You just go through there, and look at all those different diseases. They're just P's. Okay. Thousands of diseases on this database. So what do you do? So you could choose any disease you want, all right? But that's just one way of doing it. There's a Google Doc that you can, again, download as your own or save as your own. And then there's just a few questions that I want you to answer. What's the name of the disease? What are signs and symptoms? What causes the disease? Who gets the disease? How is it diagnosed? Treatment options, prognosis. That's kind of the outcome. Are they going to have 6 months to live, or prognosis is good? You should be able to live a normal life. What's the prognosis? What current research is going on, if any? And any other interesting facts. We can go to YouTube as well, or a different website. Put the link in there for question 9, and discuss a little bit about what you saw, and then you have to have a good break, great break actually. You've earned it, and that's it for the case studies. Okay, so case studies 9 through 12 are done. Now the next thing I want to go through real quick, I don't think there's a need for too much explanation with the PhysioEx activities that you need to do. There is no Unit 12 PhysioEx. So that's one, I guess, explanation. So you have PhysioEx 9, which is a respiratory system mechanics, measuring respiratory volumes and calculating capacities. That one's very straightforward. Now, these other two I highly recommend. Again, they're extra credit. So I know some of you have already done those. And then, so that's for Unit 9. So I have that one pulled up here, measuring respiratory volumes and calculating capacities. So this goes through some of the basics of respiratory volumes. This is a very good activity. It's very straightforward. I think the next one too, activity 2, is also excellent for doing comparative spirometry, kind of looking at what's going on with someone, maybe with different respiratory or COPD conditions. So anyway, this one's just going to calculate, or it's going to do most of the grunt work for you, but it's going to look at tidal volume. That's just the normal passive breathing. It's about 500 milliliters, or a half a liter. And then it looks at the expiratory reserve volume. Okay, so how much is left after we exhale, and then inspiratory reserve volume, how much is left after a deep breath in. Okay. Vital capacity, total lung capacity. Okay. So the radius, the airway radius is set to 5 on this one. So we're going to start with just initiating a normal breathing patterns with this one. So you can see the tidal volume is roughly 5. So going up the side is increments of 1 liter. So this is about a half a liter. So that's normal. That's what we would expect. And then we just click record data. Select clear tracings. Now complete the measurement of respiratory volumes and determine respiratory capacities. So first select start to initiate normal breathing pattern. Okay, after 10 seconds, we're going to select expiratory reserve volume, wait 10 more seconds, and then select force vital capacity. Okay, so click start, and then after about 10 seconds, then we're going to hit that one. Should see that. And then after another 10 seconds, we're going to hit that. Pardon me. Okay, so this is kind of cool. It shows us on the graphic what each of the items is that we're looking at. So we see again tidal volume at about 500 milliliters, and then the expiratory reserve volume. So you're breathing normal, and you get to that exhale. So notice it's on. So you breathe in normal. So inhale. So by the way, what this is showing is the amount of air going into the lungs and then back out. Into the lungs, back out. So 500 in, 500 out. 500 in, 500 out. 500 in, 500 out. 500 in, 500 out. And then we do a forced exhalation, we call it. And that's going to give us the expiratory reserve volume. So that forced exhalation doesn't start until the bottom of that tidal volume. So when we're just breathing in 500, out 500, then we start that's when I click that button, that ERV. So that's when this occurred here. So we exhaled some extra air. So it's showing how much extra air was exhaled. So we've got about another 500 and then almost another 1,000 milliliters. So about 1.5 or so for that expiratory reserve volume. They have it at 1.2. So that's good. You can see it's not quite down to the 1. So 1,200 milliliters for the expiratory reserve volume. And then we just went back to normal breathing. And then we did a big, deep inspiratory. We took a deep breath, right? Force vital capacity, but just basically we took a big, deep breath. So that we call that inspiratory reserve volume. So that's again measured at the top of the tidal volume. So we breathe in a normal breath in to 500 and then take a deep breath in. And that's what we see here. That inspiratory reserve volume is 3,091. Okay. So just that peak. And then vital capacity is going to be adding up inspiratory. So we're just adding up the 3 items we just did. Okay, so we did tidal volume of 500. Then we had 1,200 for the expiratory reserve. And then inspiratory reserve is around 3,000, almost 3,100. So we add those together and we get what's called vital capacity. Okay, so vital capacity, this number here, 4,791, is simply adding up 500 plus 1,200. That gives us 1,700. And then we add that to the inspiratory reserve volume of 3,091. Okay, so Vital capacity is these three: tidal volume, expiratory reserve volume, and inspiratory reserve volume. Okay. Now, let's see. TLC is what we call total lung capacity. Now, how we get that number is we have this little extra here. So when we do our forced inhalation and get that big deep breath in as far as we can go, there's actually still a little bit or no, pardon me, that was on the exhale. This is the exhale. So, so when I breathe in, breathe out, and then exhale, that forced exhalation that we see right here, the expiratory reserve volume, there's still a little bit of air left over in the lungs. So they don't completely shrivel up and collapse when we do a forced exhalation. And that residual volume tends to be around 1,200 milliliters. So when we add everything up, so the vital capacity is just air in, air out, plus air deep in and then air deep out. So that's vital capacity. And then the leftover residual volume added to the vital capacity gives us total lung capacity, TLC. We all need some of that, right? Okay, so vital capacity plus residual volume gives us total lung capacity. So anyhow, I'm not going to do much else with this. I know you guys, I really just wanted to kind of explain what these numbers were. I think the rest of this activity is pretty self-explanatory. Let's see, we wanted to hit record data there. So it's going to record data. Basically, we establish some baseline measurements. And then the rest of this is going to be, we'll decrease the airways a little bit, and then we'll increase the airways to see if any of these numbers are affected. Okay. All right. So let's move over to this next one. So digest. So that's for Unit 9, PhysioEx. Unit 10, PhysioEx, has you do Activity 1, assessing starch digestion by salivary amylase. This is a very quick, straightforward activity. So you want to read through all of that good stuff, and continue here. So what we have, we're analyzing starch. And again, I'm not going to go through this whole thing with you. I know this one is also very straightforward and very simple as far as the actual conducting of the lab. So what may be a little confusing is what I'm going to discuss now to alleviate any confusion. Now, starch, remember, is going to be your most complex group of carbohydrates, meaning sugars that are strung together and attached together into really big molecules. Okay, so that's starch. So that's like pastas and potatoes and things like that. Starches, rices, and grains. So we consume starches in the mouth. Um, we want to break those big, long carbohydrates into what we call disaccharides, okay, smaller two-chain carbohydrates. Okay, so maltose is one of those carbohydrates. It's a disaccharide. And ultimately, the body, deeper into the gut, right, into the digestive system, once we get into the small intestines, we can continue the process of digesting starches. So we'll have a pancreatic amylase as well as a salivary amylase. But then we also are going to see specific enzymes in the small intestines that digest these disaccharides into monosaccharides. And you've heard of these enzymes like maltase, lactase, okay, sucrase. Okay, so these ASEs are going to break up these disaccharides. But before we break up the disaccharides, we need amylase. Remember, an ASE is an enzyme that's going to break down whatever it's discussing. So Amylase breaks down starches from being big, long chain carbohydrates into being two chain carbohydrates. So maltose, sucrose, and lactose. Okay. And then we add maltase to maltose, and then we'll get our simple sugars, okay, our glucose, fructose. Okay. So anyhow, so the optimal pH then so what's the pH in the mouth? Probably around 7, right? pH in the stomach closer to 2, pH deeper down in the small intestines going up to a 9. So a pH of 7 is going to be the optimal pH for the enzyme amylase to work. So anyway, you're going to put your it tells you what you need to do and what so you drag we drag the test tubes over, and we have 8 different test tubes. So we click next, and then it tells us to what we need to put in each of the tubes. So tube 1, tube 2, and tube 3 all have the same thing. You guys see that? Amylase starch pH 7, amylase starch pH 7, amylase starch pH 7. So tubes 1, 2, and 3 are going to have amylase starch pH 7. So you just grab the dropper, click that, grab the dropper, click that. You can do it any way you want, but I'm going to do it this way. Since I know 1, 2, and 3 are the same, amylase starch and pH 7 buffer, I'm just going to do each of those first. Okay, so you just go through and do all of that. You can even grab it and click it and drop it. You don't have to do that. You can. Oops. There we go. All right. So anyway, 1, 2, and 3 done. So then you go through and fill the rest of them up with what it tells you to do, and click next, and then select the number 1 test tube. So you can select just the number 1 like that. See, and it tells us it's gonna tell us to boil it. Okay, so then we boil it. You can see it boiling. And then we're going to grab test tube 2. It's going to tell us to freeze it. So I just wanted to show you that because you just click the number and it'll drop them down. If you want to do the whole batch like this, you click incubate and it'll drop all of them down. So anyway, you can go through that one. It's pretty straightforward. Let's see. And then the last two so your last 2 PhysioExes go with acid-base balance, exercise 10. It's going to be activities 3 and 4. They're very short. They're very straightforward. Basically, what they discuss is that the respiratory system's your primary balancer for pH, and so carbon dioxide. We get rid of carbon dioxide because too much of it causes a hydrogen ion concentration to be too high. When hydrogen ion concentration is high, that means the pH is low, which number is low, which means things are very acidic. So a pH of 1 or a pH of 2 means we have way too much hydrogen ion in the system, which also means we have way too much carbon dioxide in the system. So 2 ways in which we balance out pH is by getting rid of carbon dioxide and peeing out excess hydrogen ions. So we can eliminate hydrogen ions in our urine. So the kidneys help as well with balancing pH. Okay, so respiratory, get rid of it. CO2, urinate, hydrogen ions also helps with pH balance. Okay, so we can lower the amount of hydrogen ions, increase the pH number, which actually puts us closer into that neutral range. If we go too far into neutral or past neutral on the pH scale, so we don't have enough hydrogen ions, then we can retain hydrogen ions from our urine. Okay, so we're not going to eliminate as much hydrogen ions. We want to retain it. So if we have too much hydrogen ions, we call that alkalosis. If we don't have enough, or we call that acidosis. So too much hydrogen ions means acidosis. Okay, that means you're having a low pH. Remember, the pH is little p, big H. That big H means hydrogen ions. Okay, and the number is that it's the negative exponent in our base 10 formula for talking about hydrogen ion concentration. So a pH of 1, it means we have a lot. It means we have 10 to the negative first amount. So 0.1, 10 to the negative first is 0.1 amount of hydrogen ion. That's a lot. If we have a pH of 7, that means we have 10 to the negative 7th hydrogen ions in the body. So that's 0 point and then 6 zeros and then a 1. So that's a very, very tiny amount of hydrogen ion. So the higher the pH number in actuality means the lower the amount of hydrogen ions in the body. Okay, so and the lower the pH number, the more acidic you are, right? Or not you are, but the more acidic we're dealing with. All right. So anyway, this is what this discusses: renal responses to respiratory acidosis and respiratory alkalosis. So respiratory acidosis just means that the lungs are retaining way too much carbon dioxide. Okay. Respiratory alkalosis means they're getting rid of too much carbon dioxide. Okay. Hyperventilation and hypoventilation. And then, so the kidneys will respond if the lungs can't. That's what that's saying. And then the lungs respond when the kidneys can't. So the kidneys help with metabolic acidosis. So too much hydrogen ions, the kidneys will pee it out. Not enough hydrogen. So if that doesn't work, right? So the kidneys are not able to pee out the excess hydrogen ion, then we're going to have hyperventilation. We're going to get more breathing. Okay, because that's how we're going to respond to too much hydrogen ion, meaning too much acidity. We're going to breathe more. Okay, so that's what these two PhysioExes go through. Again, I don't want to ruin too much of the surprise for you, so you can go through these. Are very straightforward. If you do have questions on these, again, just let me know. So this is the renal response to respiratory acidosis and respiratory alkalosis. So partial pressure is CO2. So this is how much carbon dioxide is in the blood. We're going to start at a normal range of 40. And we're going to watch that go through, and then we're going to measure the hydrogen ion concentration. And then this is bicarbonate. Bicarbonate's the buffer. So usually if we see a lot of this, we're going to, it usually means we don't have enough of this. So too much. So in this situation, we have normal ranges. So we're going to record that. So we've got partial pressure carbon dioxide. So the amount of carbon dioxide in the blood is 40 millimeters of mercury, and that puts the blood in a normal pH range, which is going to be between 7.35 and 7.45. So as long as we're between 7.35 and 7.45, our blood pH is in the normal range. All right, so let's see, we need to refill that. So hydrogen ion concentration and bicarbonate ions are going to be both normal. All right, so we recorded data, we hit next, we hit refill. Now what do we do? We're just gonna do this and this. I'll let you read those and do those on your own. All right, lower the lower the amount of carbon dioxide. So to 30, the corresponding increase in blood pH. So not enough carbon dioxide, remember, means that we're going to be in an alkalosis situation. So the lungs, there's partial pressure carbon dioxide has gone below normal. So what that means is our pH has gone higher, which means we're in an alkaline situation. Remember, above 7 is going to be considered alkalosis or alkaline. So let's go ahead and hit start. Let's see what the kidneys do to balance that out. Okay, so the blood pH is going to be a little bit too high. So we need to lower this. So are the kidneys going to eliminate hydrogen ions or retain hydrogen ions? Hmm. Okay, so in the urine, we're going to see decreased levels, right, of hydrogen ions. So the body's going to retain hydrogen ions so we can get this number to go down closer to 7.4. Okay, 7.35 to 7.45 is where we want that number to be. Okay, so again, not enough carbon dioxide. Okay, not enough carbon. And then I think, hold on, let me go back. Not enough carbon dioxide means, again, we're in an alkalosis situation. So we need to retain. Okay, what's this? The condition you just simulated was respiratory alkalosis. So this individual respiratory alkalosis. So they got rid of way too much. They hyperventilated, so they eliminated too much carbon dioxide. So the carbon dioxide levels went so low from hyperventilation, it caused respiratory alkalosis. So what the kidneys did is they retained hydrogen ions, so we could bring that level back up. All right, so we refilled. I think we already did that. So we hit next. We come up here. What do you? Oh, wait. This is a predict question. So we're just gonna hit the last one. I don't want again. I want you to do your own predictions. All right. So now it wants us to put the partial pressure of carbon dioxide up to 60. So now there's way too much carbon dioxide in the lungs. That's going to be a hypo ventilation issue. So now the pH level, notice we have excess amount. Remember, when the pH is lower in number, it means there's too much hydrogen ion. I know it seems counterintuitive, but that's the way pH is. It's counterintuitive. Remember, the big H is for hydrogen ions, and the it's a concentration gradient, and the lower the pH, the more hydrogen ions. So the body is going to compensate for all of that excess hydrogen ions by peeing it out. So we're going to see elevated levels of hydrogen ion in the urine. And then the body is going to retain this buffer. This is the bicarbonate ion buffer. So we need to retain um, buffer because of the acidity issue. Okay, and that's it for that one. I do believe. Yeah, that's it. So that one's very straightforward. The next one is pretty much identical. We just go in a reverse order. This time we're dealing with the lungs and the respiratory system and how it compensates when we have the reverse problem. So I'm not going to do this one. I want you to do this one entirely on your own. I think you'll do just fine. And again, if you have questions, just send me an email. And if you need to meet in Zoom, let me know. Other than that, that concludes everything for the semester as far as case studies and PhysioExes. If you, again, ever need anything or ever have questions down the road, please send me an email and keep me updated and keep me posted. Other than that, have a great summer, and I hope you enjoyed advanced A&P and are going to be able to. I know all of you are going to take this information and be able to use it in the field as well as in your other classes, and certainly, most importantly, maybe in your own personal lives and trying to maintain some sense of homeostasis as often as you can and try to maintain healthy boundaries and a balanced life so you can work a long time and be around your families and friends and enjoy your lives without having to worry too terribly much about illness and disease, except as it applies to you as a caregiver and as a worker in the healthcare industry, not necessarily as the patient in the healthcare industry, right? So anyway, all of you will do wonderful, and good luck to all of you.